Thank you, Paul. Staying in the Anglo mode, but moving to the Southern Hemisphere, Kathryn North will talk about the Australian Genomic Health Alliance.
Thanks very much. So what I'm going to talk about is two areas. Australia has a state-based health system in that our state governments actually finance our hospital system. But we have a federal health system run out of our federal government, which supports Medicare, which is a bit like the NIH in terms of funding drugs, prescription drugs, actually funding tests that are done in hospitals. So we've got this strange interplay between state and federal governments. And it's within, I just set the scene for that environment because that has really provided the basis for the approaches that we've taken into how do we integrate genomics into healthcare. So we started locally, and we started in Melbourne, which is in the state of Victoria, and with a goal that was really about how do we embed genomics into healthcare. And the approach that we've taken is that it's clinically driven. It's starting with the patients in the clinic. It's shared and collaborative across the organisations that I'll show you. And that as we produce clinical genomes, in actual fact, we're starting with whole exome sequencing with targeted analysis for specific disorders. Those sequences are then readily available for research use. So this actually started as a self-funded project across a number of all of these institutions in the Melbourne area, and we each put up $250,000 each to have a pilot project funding of $2 million for the first year as a demonstration project. So over this 12-month period, we did prospective recruitment aiming for 200 patients. As I said, whole exome sequencing with targeted analysis, and in parallel with usual investigations. And this is meant to represent that we were laying down the tracks within the healthcare system as we went along. We were looking at genomics as a disruptive technology and that we needed to take a whole-of-system approach. So this was really, I think, a health services research project. This is just, you don't need to read any of this, but it's really just to give the idea of the whole-of-system approach that we took. We really had to work across a number of different hospitals, the research institutes, universities, areas where the sequencing was being done. We were mimicking it and actually inbuilding it into the health system. So using the diagnostic laboratories to do the sequencing rather than the research laboratories. We're pulling together our bioinformatics expertise across 3 different institutions to adapt and create the final pipeline that we would use in the diagnostic laboratories. And then we're bringing together the bioinformaticians with the molecular geneticists, with the clinicians to actually sit together and look at the analysis of the sequence to rank in terms of diagnostic likelihood. So the systems that we have operational over this first year as we, across the institutions, developed a shared ethics and consent with agreed standards and guidelines for how we present results back to patients. A common bioinformatics pipeline, and at all times we're learning from what was happening at different institutions overseas. A variant curation database that is accessible across all the different institutions, the multidisciplinary review teams, and also these ongoing groups that are working together to see how we continually review and refine the process, particularly in the area of bioinformatics, but also in that bugbear, the clinical interpretation of results. So at the end of this project, we enrolled 220 and we're going through an evaluation process at the moment. As I was talking about yesterday, what we needed to demonstrate for our governments to change policy is that we could demonstrate clinical utility and that we're also cost effective because we're comparing at all times the patients that we enrolled prospectively had their usual path of diagnosis at the same time. So we're doing the 2 in parallel. And for example, for the childhood syndrome group of disorders, the standard of care that happened as part of their usual diagnostic process had a diagnostic success rate of about 20%, whereas with a targeted analysis of whole exomes, we had a diagnostic hit rate of 54%. So we can immediately demonstrate clinical utility so that this can be seen as a first-line first-line test. And particularly what we're going after is for our federal government to fund an exome approach as a first-line diagnostic test in suitable cases. Our state government has recently invested $25 million with our core group, and we're going to take for the next 4 years to expand this so that with the end point in 4 years' time is that this is how our state health system runs from a diagnostic perspective. That is the end goal. And we're also expanding it so it's extending across all of state. So I'll finish off then is what do we then do with Australia? We've got multiple states and 2 territories, and the approach that we've taken here is that we want to continue this model of collaborations between what is happening with centres of excellence in research that can then take the cases that we're not diagnosing, but also partnered with our diagnostic pathology services. And so over the last year we've formed this alliance of over 41 institutions around Australia, all the genetic services, the state diagnostic pathology services, the major academic institutions, in terms of how we start to approach this in a whole of country approach. And this also, there has been a central call for federal funding in terms of how we develop a national collaborative approach. And my last slide here is, my second last slide, is what we've done over the last year is to map across Australia our genomics workforce, benchmarking it against other countries and what is needed from a counselling and clinical point of view, looking at our genomic testing practices, our functional genomics and our data infrastructure to identify the gaps. And this is the program of work that we're proposing, particularly to look at routine testing being done in each state, and by routine that'll be whole exome and then whole genome, but then to have national referral centres where for specific disorders we can then start to tackle the harder cases. We're looking at a federated data repository, and at the same time we're doing continuing prospective economic analysis so that we're influencing federal policy. Where can the Global Alliance help? Well, I've actually found the Global Alliance to be incredibly helpful at all steps of the way as I've been learning as we've been growing. But it's certainly the areas that we talk about, particularly relating to all of how we're standardising, how we're actually now linking our phenotypic data within the electronic medical records and then linking that to genomic data. We use the standards, we learn from the consents and the code of conduct that's been developed. But really, the systems, our challenge is how do we take this to a national system of federated data sharing? And that's probably, that I see is probably the major issue that we will grapple with. So, happy to keep you posted. Thank you.